providers not actively involved in treatment, such as primary care. You can go to the next slide, please. So I wanted to highlight an RFA, which is a request for applications that we published in 2019, and it was entitled Optimizing the Management and Outcomes for Survivors Transitioning to Follow-Up Care. This was focused on developing and testing models of care for adult survivors of cancer transitioning from active treatment, so earlier stage disease. And we asked applicants to propose a multi-level intervention aimed at enhancing those things: communication, collaboration, and coordination between providers. Next slide, please. I wanted to highlight a few of the strategies that we're testing through this RFA. You can go ahead to the next slide, please. And that includes provider activation with self-management. So that's empowering and educating primary care providers and survivors. An embedded primary care provider model where primary care nurse practitioners work within an oncology practice to care for low-risk survivors. Survivorship geriatric evaluation and management intervention, and that's for older adult survivors delivered by oncology advanced practice providers. And then an advanced practice provider-driven telehealth survivor self-management. And that includes care coordination and communication, clinician care plan for primary care providers, and geriatric assessment. I'll say that we have some early takeaways from these projects. And really, it's that engaging primary care providers is challenging, and we have to consider their bandwidth, their needs, and their strategies. Next slide, please. So at this point, I'm going to shift a little bit, and I wanted to highlight a recent project. It was led by Elise Garten. I want to give credit to her for these slides. And she led, along with other colleagues here at the NCI, a review of survivorship objectives in national cancer control plans in Africa. So this is part of the Africa Survivorship Working Group. It's a subset of the Africa Cancer Research and Control ECHO, which many of you are likely a part of. And the objectives of this project were to examine how survivorship care is represented in national cancer control plans in Africa, and to disseminate the findings to African regional and international collaborators to further address and improve survivorship care in the region. We did this based on a project that I led in the US, looking at survivorship objectives and how they aligned with National Academy of Medicine recommendations for survivorship care. Next slide, please. So to do this work, we reviewed current or recently expired cancer control plans from 21 countries in Africa. We extracted survivorship content from their strategies and their objective sections. 6 coders then worked in pairs to assign domains to each of the objectives. Again, we use the Institute of Medicine or National Academies of Medicine survivorship recommendations. Elise led the modification of those recommendations to be less US specific and more tailored to the African nations. We also added access to medications as an 11th domain. So we analyzed results, we reviewed them, and we used them to generate survivorship country profiles to aid in the translation of those results to plan future policies. Next slide, please. So these are some examples of the strategies that we extracted. The first was under the domain of utilizing evidence-based guidelines. From Kenya, it says work in collaboration with the Ministry of Education and relevant key stakeholders to develop guidelines for the support and rehabilitation of children and adolescents with cancer. You can see an example of models of coordinated care, where the objective is develop supportive care for patients and their relatives involving others. And then finally, access to medicines in Mozambique was develop a plan to manage medications, supplies, and devices that ensures the availability of opioids and other medications for pain control. Next slide, please. You can see our results here that of the plans that we reviewed, a total of 202 survivorship strategies across those 21 plans were identified. All of the plans had at least one survivorship strategy. You can see they range from 1 all the way to 23 survivorship strategies. I want to point out that in many cases, and in the paper we pulled this apart a little further, palliative care was a driving force and was overlapping in many of these strategies for good reason, and palliative care was a focus in the cancer control plans. Next slide, please. You can see the domains in the Institute of Medicine or National Academies of Medicine recommendations, all the way from raising awareness down to access to medications. You'll see that when we looked at the domains, they were not evenly distributed. So a lot of references were made to models of coordinated care and healthcare professional capacity or the workforce. Very few references to survivorship care plans, and no references in the strategies or objectives to adequate and affordable health insurance. Next slide. So there's several implications of this review, and we feel like this serves not only as a basis for the African region and the cancer control plans in those countries, but also in other countries to examine their own cancer control plans. First, models of coordinated care and healthcare professional capacity was most often included, which is not surprising given the funds that account for healthcare workforce capacity. There were no national cancer control plan strategies in the domain of adequate and affordable health insurance, despite this being a key component of survivorship. We feel like these indicators for the strategies are a best practice to ensure accountability, but we found that they were only present on 40% of survivorship-related strategies to be able to evaluate the implementation of those objectives. And finally, only 37 of the survivorship-related strategies were not specific to palliative care. So that suggests that comprehensive recognition of survivorship as a separate and distinct element is not yet present, and we need to think further about how those overlap and how best to disentangle them. Next slide, please. And finally, Elise led the development of profiles for each country in this review. And this is an example here. These are up on the ICCP portal and are publicly accessible. So they contain data in the graphs, some concrete recommendations for what countries can do to strengthen survivorship-related strategies. And then finally, on the backside, it includes all of the domains and the representation in the current plan. Next slide, please. So at this point, I'm going to switch into some relevant funding opportunities and events. I want to just comment that the NCI obviously has funding opportunities that are only open to US investigators and institutions, but I've highlighted a few that are open outside the US. So I'm going to first start with two previous funding opportunities. These were not open outside of the US, but they do highlight scientific areas that we have tried to champion. The first is research to understand and address the survivorship needs of people living with advanced cancer. And this was intended to support observational and interventional research to try to drive research in this area. We had 2 receipt dates, and we're currently funding grants from the second receipt date, but we're really excited for investigators to start thinking about this area as a growing population. And internationally, we're seeing growth of this area as well, and I think it will become even more important to be able to address the needs of people who are living long-term with cancer that is likely incurable. Next slide, please. And the second previous funding opportunity was focused on primary care needs of cancer survivors. This had a receipt date in 2023, and the goal here was to support the development and testing of primary care practice and health system level interventions and strategies. Our overall goal was really to support primary care providers in caring for the millions of cancer survivors that they see per year, especially in the US. This has a lot of relevance outside of the US and globally as well. Next slide, please. This funding opportunity is improving care and outcomes for cancer survivors from sexual and gender minority populations. I want to also note before I describe this funding opportunity, this is open for foreign institutions to apply, for foreign components, and for foreign collaborators or international collaborators outside of the US. The key scientific areas for this funding opportunity is understanding and or addressing barriers to cancer treatment and follow-up care for this population, characterizing and developing approaches to address factors that increase risk for poorer outcomes, and testing interventions to improve modifiable risk factors for cancer care. Next slide, please. We also have a new RFA that is being led by the National Institute of Aging within the US National Institutes of Health. It is a consortium for palliative care research across the lifespan. And given the focus in palliative care internationally and globally, I wanted to highlight this opportunity. While non-US entities are not eligible to apply, you may include foreign components or components outside of the US in a domestic application. So if you have collaborators in the US, you may apply for this. The goal here was to develop a coordinated infrastructure for palliative care that is inclusive across the lifespan and across serious illness. Cancer is definitely of interest. The NCI has signed on to this RFA. I'm the scientific lead, so if anyone's interested in learning more, I'm happy to follow up with you. Next slide, please. And then we recently held a workshop, Enhancing Capacity for Primary Care Research and Cancer Survivorship. Some people on this call were in attendance for that meeting as well. The purpose of this workshop was really to explore opportunities for us to drive capacity and to improve capacity for conducting research on primary care and survivorship. A next step of this work is going to be the development of a community of practice or some sort of network, and we're working on that now. So you will see more to come from the NCI on this. Really, the goal is to facilitate collaborations that span different research disciplines and areas. We had 3 interactive sessions during this workshop, system level interventions, identifying survivors in primary care, and mentoring and team building. And the recordings from all of that will be available very soon. Next slide, please. And the Office of Cancer Survivorship has other events, including the OCS Director Series and the New Investigator Series. Next slide, please. I wanted to highlight just a few, and I know this is a quick overview. Tomorrow at 2 o'clock Eastern Time, we have a new OCS Director Series focused on AYA cancer survivorship. And that is from Dr. John Salzman and Dr. Lauren Gazal, who is a cancer survivor and will be reflecting on her experience. Next slide, please. And then in May, we have High Quality Care Without Breaking the Bank. And this is on financial hardship by Dr. Veena Shankaran from the Fred Hutch Cancer Center. So we're very excited about this. All of our events are on our webpage, and you can view past recordings from any of our events as well. Next slide, please. So I'll end just by giving you some key takeaways of survivorship care and strategies for dealing with all of these challenges. I would say that relationships are key. We need to engage the full team, and that includes advanced practice providers, primary care, oncology, and specialty care in a multidisciplinary setting to really tailor care based on the needs of the survivor. We need to show return on investment to get buy-in for survivorship care within healthcare systems. Often reimbursement can be a challenge. And so considering ways to really show improvement in outcomes for survivors is essential. Survivors need to be prepared. So we utilize the definition of a cancer survivor from the time of diagnosis forward. And that means that we need to start the conversation early. We need to listen to survivors. What do they need and when do they need it? Next slide, please. And I will just end by saying that survivorship is a time of great opportunity. We have an increasing attention to the needs of survivors long term. We have a growing appreciation that differences in care can lead to disparities in outcomes, and that means that we have a call to action to improve care, especially for those that are experiencing access issues and issues with outcomes and late and long-term effects. We have substantial advances in technology and telehealth, although there are disparities in that as well. That enhances our ability to both intervene with survivors and to capture data. And we have a growing number of researchers and clinicians entering and interested in survivorship science and practice. And I'll end by saying that the advocacy community within survivorship is strong, and we partner with them regularly on projects and on our initiatives. And we're very grateful for that activation and empowerment from survivors. Next slide, please. I will end by just saying thank you so much. Thank you, Tanya, for the invitation. It's been great to be here, and I'm happy to take your questions.
Thank you so much, Michelle. This is a great presentation. There are questions already, so I will call on Dr. Ngozi. You have a question. Please, you can unmute and ask your question.
Okay, thank you, Professor Sonia. Thank you, Michelle. This is really interesting. And this presentation has actually raised more questions in my head concerning survivorship. So I would like if you could differentiate between survivorship, palliative care, and hospice. If you can give us a little bit, let's know the difference between these three.
Sure, that's a great question. So yeah, that's a great question. Thank you so much. I will first say that we see survivorship care as attending to the needs of a person from the point of diagnosis forward. And what that means is that it overlaps with palliative care, right? So survivorship care includes anything from monitoring for recurrence and new cancers to monitoring and addressing late effects to acute effects of cancer and its treatment, anything that plays a role in sort of the experience of a survivor. Palliative care we see as supportive care, and there are recommendations and guidelines that should happen from the point of diagnosis forward, which means in some cases those are overlapping. There's some really great papers, happy to follow up with you later about that overlap and where survivorship is and where palliative care is. And then we see hospice as end-of-life care. So truly when a person is in need of care in the time leading up to death. In the United States, that's about 6 months for entering into hospice care, but although that's changing a bit, and then into bereavement. And I would say that they all have overlapping components, but I would say that that's sort of how we operationalize it in this country.
So, Michelle, if I could ask just a little bit more clarifying for me,
sure.
Because this was a very important thing. So, and I'm going to say this from a non-oncologist point of view, and I want to see if I'm right in how I'm understanding it. And I'm understanding it that, survivorship, you could say, looks more like palliative care, but focus more on the medical needs, while the palliative care focus more on the supportive needs, even though it includes symptom management. Would that be correct?
I think that there's components of supportive needs in both of those, so I'm not sure I can exactly answer. I think that in some cases we see palliative care happening when there are needs that go above and beyond what an oncologist and a primary care provider can handle and really need specialty palliative care. So it goes a little bit beyond that. But I would say that you're right. I think the distinguishing factor in survivorship is looking for things like recurrence and second malignancies and late and long-term effects, those kind of things. Whereas palliative care often is sort of during treatment and as people transition into end-of-life care.
Thank you.
Mm-hmm.
Okay, thank you. There's a question in the Q&A. It says, so what is, well, you've answered part of that, which is what is the role of palliative care in cancer survivorship?
Yeah, that's a great question. So I would just say that I think, especially in the US, and I would garner that this is also true globally, there are capacity issues. So I see that survivorship providers need to work together with palliative care providers to be able to provide really a comprehensive supportive care environment. Palliative care providers also are really adept at handling changes in prognosis and that sort of uncertainty. And so having conversations around goals of care, advanced care planning, they are incredibly experienced in that area.
Michelle, I have a question. since if I
Sure.
don't see any, unless there is one, Professor I can wait. But if not, then I can go ahead with my question.
Yeah, no, go ahead because I don't see any in the Q&A.
Okay. So this is something that I wanted to, I'm a non-oncologist. My research focus is on implementation science. And we have a current NCI grant looking at the integration of cervical cancer in HIV programs. I'm an infectious disease specialist by training. So we have a large practice-based research network in Nigeria that have 12 model sites across the 6 regions of Nigeria. As part of that practice network, we have oncologists, we have palliative care people, we have neurologists, we have cardiologists, all in that. The challenge in Nigeria is that most of those expertise that you talk about are all in the teaching hospitals, in the university hospitals. These are in the major cities. For example, our 12 sites that we have across the country, one of the conditions, for example, is that your site have to at least provide care to 1,000 women with HIV. None of the tertiary centers qualified because none of them have that large number of people. So you see that most of the people who are living with this disease are not receiving those cares in the tertiary centers where all the resources are being put in. Our government, which is the government of Nigeria, has put in a recent funding to, of course, expand things and facilities that are available and those tertiary centers. And those tertiary centers are important because you can't, of course, fund every small clinic around the country. So they are very important to be funded as a referral center. But what we're trying to build, and this is where I need your, is when people go into those tertiary centers and receive the immediate care they need for whether it's treatment, the therapy, and all the things that are there, they're not going to live there forever. They're going to go back to their rural areas. So our focus is that how do you support people in that rural area so that with the coordination, of course, with the tertiary center, so the kind of things that we're trying to build, we thought we were going to build more like palliative care services where there are no palliative care specialists. But hearing you talk, I almost think like we need to also include the survivorship as part of that. When there is no, because they can always come to the teaching hospital to get their CBC or Y count, or they might come there to get their mammogram or another kind of screening. But even the small monitoring that you want to do, they could do that in their own local general hospital, which is county hospital, which is where we are focused in the rural areas. So how will you suggest such a program that is being designed for rural areas? Should we be combining palliative care and survivorship, or should we just focus more on survivorship, on palliative care because it's more supportive? It's a long question, but I don't know if you got my
No, that's okay.
drift.
Yes, I think I get the idea. That's a great question. I would say that I think that there is a need to enhance survivorship care, particularly for people treated outside of those academic centers. The NCI Center for Global Health leads a great, that Africa Survivorship Working Group that I mentioned leads a great ECHO for training providers. So I think there is a place for that. I also think to the extent that we can promote supportive self-management, and that does not mean that people go out and do things on their own, but that survivors and patients know when to call and who to call for the right types of services. And I think there's components of survivorship care and components of palliative care in that. I would say that that's what we need to focus on, having people know the right time and when to contact people and for what. And then I will also add that I think the communication and collaboration with providers that are outside of those academic centers, so not only teaching them to provide the care that they need to do, but coordinating that care so that there's not duplication of services. And so I would say that that spans palliative care and survivorship. Hopefully I answered your question.
You did, and I will let you answer the other ones with my last question, which is, so one of the things we're trying to coordinate is that the kind of, that we create a home for those cancer survivors in those county hospitals, so that when someone is being treated in those teaching hospital and university hospital, and they're going to be going home, they can at least talk to the doctor who is going to be home, even if that person acts more as a triage provider. You know what I mean? To say, I
Right.
think I can take care of your pain and this, but the complaints you're taking, I think you need to go back and see your oncologist. Because the truth is that trying to bring them always back to the oncology is one of the things we notice in Nigeria is lost to care continuum. So you give them radiotherapy, you give them everything, and then you send them home, and then you want them to come back. The next time you see them, they have another cancer that you could have done something about earlier, but it will be too late. So we see a lot of late diagnosis in Nigeria, and we think that some of that is from that disconnect of when you are sending somebody back, who is at home, which provider, whether it's a nurse that is there, whether it's anybody in the healthcare field that can even act as a triage provider to say, this, I think you need to go back to oncology. This, I think you can, something like that. That's what we're trying to build. I'm asking this because we are meeting next week with the providers from all over the country, palliative care specialists, and we're actually looking at faith leaders. We're looking at traditional healers. We're looking for all the components of people who can provide there, but it's being led by our the Association of Palliative Care Specialists in Nigeria, which of course, Tonya is the president.
Yes.
So they're all bringing together. So we're all going to be meeting for a whole week next week to try to see whether we can actually bring in a real concept of these are the services that are needed. We have patients also included in this. These are the services we think are needed in areas where you need palliative care, but there are no palliative care specialists. So how do we create that in those areas with the support from the Palliative Care Association? So I hope that you see what we're trying to do, and
Yes.
I'm very happy that I attended this. Thank you so much.
Great. Thank you. Thank you. It looks like, Tanya, there's a few questions in the chat. So maybe I'll go ahead and touch on those. So one of the questions was, what are the research opportunities, especially in middle and low income countries in the area of survivorship? That's a great question. Our certainly funded by the US, the Centers for Global Health has many different research opportunities and funding opportunities, and I know they've been involved with Tanya and others. I would say that I think the areas of coordination of care through things like navigation in survivorship is an opportunity. I think an opportunity is to look at the financial impact, particularly in people that are treated long-term for survivorship needs. And then I would also add that people are living a lot longer with cancers that are incurable. So advanced lung cancer, other cancers where they really do have ongoing survivorship needs. I think there's a lot of opportunities globally to be able to address their needs in a resource stratified way. So for low income economies and countries. And then the other question from Gloria was, what are other ways to get care apart from the palliative medical care provision, especially in low-income economies? That's a great question. We see a lot of community health workers providing care and support. So people in the community that are trained lay health workers, particularly in low-income economies, we see that a lot. I think that we can train general practitioners and primary care providers to provide a lot of this supportive care. And so I think that those are some opportunities. I think I got them all, Tanya, but please let me know if I missed anything.
Questions in the Q&A?
Yes, the Q&A. So there's a question that says, at what point is a cancer patient termed a survivor?
Yeah, so that's a great question. We see a survivor from the time of diagnosis forward, so all the way through. I will say that many settings do not recognize a survivor until after their treatment has ended. So that would be for more early stage. That often depends on the resources of the institution or healthcare system. So sometimes they don't have resources to be able to offer to survivors from the point of diagnosis forward. But the key is that they have needs that span from during treatment all the way long-term after.
Okay, that's about all the questions.
It's a great question.
Can I ask
okay.
one more question? Okay,
yeah,
so
go ahead.
I want to find out if one can integrate survivorship care with palliative care. And at what point? Is it that we start with palliative care, then move into survivorship, or they can be integrated together?
Yeah,
That's one question.
Yeah, that's a great question. Sorry,
Okay,
go ahead.
so can survivorship care be applied to other chronic illnesses apart from cancer?
Great question. Okay, so the first question, can they be integrated from the point of diagnosis? I would say absolutely yes. There are successful models where, and this, I will say it with a caveat that this often happens in higher resource settings, so academic centers, so it would need to be applied for a lower resource setting, where survivorship really starts at the point of diagnosis, and the palliative care provider is also involved to talk about advanced care planning and goals of care for during treatment and after, while the survivorship provider is really the one managing surveillance for new cancer, screening, recurrence, those types of things. So I think they can be integrated well. There is often overlap in the types of care like we've talked about. So I do think you need to be clear in who's doing what. And then your other question, can you repeat that one more time, Ngazi?
Yeah, it said survivorship care can be applied to other chronic illnesses apart from cancer.
Oh, that's a great question. So I would say that palliative care obviously is applied in other chronic conditions. Survivorship, not as much, with the exception of things like post-traumatic stress or survivorship for people that have had other chronic illnesses that have resolved. I would say that we see palliative care mostly integrated in other conditions and less so survivorship like we do in cancer survivorship.
Okay, there's another question for you in the chat.
Okay. I see cancer treatment is always very expensive. Is there a way one can get subsidized treatment? This is an issue that is pervasive, but among multiple countries. I don't know that we've solved it yet. I would also say with all of these newly developed treatments, the cost is astronomical. So I don't know that I have an answer for you yet. I know that there are plans and there are pharmaceutical companies that, especially for clinical trials, will subsidize those treatments, but I do think that's a challenge.
So I just want to add here because I mean this obviously is going to be country dependent. Even the cancer treatment in the US is expensive, even as a high income country. So more so it will be in countries like Nigeria where we're even talking about getting diagnosis being expensive just for screening and prevention. But one of the things that is increasing, especially in countries like Nigeria, is clinical trials, and that's one of the reasons we also were working on the practice-based network to reach people where they live, so that majority of those people who are in those areas know that one way participation in clinical trial, we actually have a supplement from NCI that we worked on looking at people, individuals who have cancer and some of them who have gone treatment but will be considered survivors, but also to be aware about what are some of the challenges, barriers that about being participating in clinical trial, because that is one way that you can get treatments. A lot of treatment in cancer is also still experimental, which means they work, and some of them have been tried only in high income countries. If you wait till they come to Nigeria, that will be about 10 years, 20 years later. So being part of clinical trial gives you access to current trials, especially when other things have been tried that may, maybe somebody has had surgery, had radiotherapy, and had a recurrence. And if there is a clinical trial going on, that may be something that is important. But one of the things we hear about is stigma a lot about cancer. So how do you address those? I mean, in certain places, they have a lot of stigma, and we see that in HIV. But you would think that cancer, people wouldn't have stigma about it, because in HIV, we thought it was because people think it was related to life, life activities, and so they might think it's a life choice. I don't think maybe a few of them are like smoking, but most of the cancer that happen, like breast cancer, cervical cancer, isn't some, well, I guess cervical cancer, but how do you reduce stigma that is associated with cancer that actually helps women who have cancer not feel ashamed and maybe be more open to be involved even in clinical trials to reduce those costs?
Yeah, there's a lot. There's actually a lot of different cultures that have feelings and shame around cancer and a cancer diagnosis to the point where people will not talk about a diagnosis, which leads to misinformation, to not educating your family on perhaps genetic risk. I think that we need to do our best as providers to educate our patients on the fact that cancer is not should not be something to be shamed, but it's hard to overcome. I think it starts with understanding different cultures and how they feel about a cancer diagnosis. It definitely happens, certainly in the US and globally. And thank you for your points about how you're working to improve clinical trial enrollment and access to care. That's amazing work.
Thank you. There are more questions for you. So
Okay.
Mary says, is there a model that is used to categorize those receiving palliative care from those who should be receiving survivorship care?
Not necessarily that I know of. So that's a really good question. I would say that it's really so tailored based on the needs of the person as they're going through their diagnosis and their care and then their follow-up treatment. And perhaps, Tanya,
Okay,
when
another question. Yes.
sorry, I was going to say, Tanya, when you share the slides, I'll send you the paper that I referenced about the overlap between survivorship and palliative care. I think that might be helpful for people who are interested.
Yes, it will be. Yeah, and of course, as you know, I'm on the Africa Survivorship Group.
Yes.
So I'm there. Yeah. Okay. So there's another question, very interesting. It says, you mentioned health insurance scheme as one of the barriers to cancer survivorship. So how can this barrier be taken care of, especially in low middle income countries where health insurance schemes are not implemented adequately?
Yeah, that's an excellent question. I think for us, it starts with understanding and screening for people who are at high risk for having financial difficulty paying for treatment. Paying for screening, diagnosis, and treatment all the way through, and then doing our best to connect them with things like NGOs and other nonprofit organizations who might be able to provide resources. So I don't know that we can exactly fix the health insurance scheme that you're referencing, but I do think that there are resources as long as we can start to understand who is experiencing these challenges.
I think I wanted to add something in terms of context, because even again, I try to compare challenges that still exist even in high income country. It wasn't until maybe after Obamacare or after those that people before you actually excluded for having cancer from health insurance even in high income countries because it's a high expense, right? So it is a challenge there. I think one of the things is, to understand, to highlight the people who have cancer do survive. And I think it's important because when you do that, especially in low and middle income country with limited resources, they're trying to make sure that the money is being spent. And if they realize that this money is being spent in cancer and that cancer is not a death sentence, it's more
Yes.
likely that you are going to get those things being covered as part of universal health insurance coverage. Another thing that is there is to raise the awareness. I always think that, we're talking about for LMICs, their focus should be early diagnosis because early diagnosis leads to cure. So instead of waiting for somebody to have cancer and thinking about how to put the resources to take care of the cancer, you should focus also on early diagnosis. Look at what is happening even in Nigeria in cervical cancer. That if you're able to use what they use now, which is VIA, visualization with acetic acid, and you're able to see precancerous lesions, and you're able to treat them on the spot with thermal ablation. You are not waiting for people to present with terminal stage cervical cancer and pouring the funding into that. So being able to spend that money on the early screening for cervical cancer, where you can still identify precancerous lesion and be able to treat that. So what's one of the things we're finding, in our study that is on across all the 6 regions in Nigeria, is that when you actually identify this early, that the treatment can be very, very complete, and also can be less intensive in terms of cost than when you wait for people to now have cervical cancer advanced stage and trying to treat that. Thank you.
Very true. Excellent.
Yeah. Thank you so much. So I don't see, let me see, any question? Okay, yes. So Dr. Azeze is asking, are there any outstanding research outcomes that contribute positively to managing cancer or reducing the occurrence? The she hopes is not outside the scope of this presentation.
So I just want to make sure that I understand the question. Are there strategies that have been shown to be effective for improving outcomes? So I would say that the health behavior space and the physical activity space have shown a lot of efficacy on outcomes. That's probably where I would start. And then screening for recurrence and new cancers has definitely shown to reduce mortality.
Okay, thank you. So I don't see any more questions. And Michelle, we really want to thank you for spending time with us today with this very enlightening and interesting lecture. We want to say, when we call upon you again, would you kindly answer us? It's really interesting.
Of course.
I think we need to have a part 2 because I have some friends who are chatting me up and saying we want to ask some questions, but the time is fast spent. So
Sure.
thank you
Sure,
so
absolutely.
much.
Thank you so much for the
Thank you.
invitation. It's been great to be here. Have a great day.
Thank you.
Michelle. Thank you so much,
Bye.
Michelle. Thank you.
Thank you.
Bye.
Thank you. Thank you, everyone, for attending. See you about this time next month for the May webinar. Take care and have a nice week. Bye-bye.
Professor Nyeka, it's important to actually bring up what our next month is. So what is our next month on?
Oh, okay. I don't have it at the top of my head, but next month we'll be looking at research in underrepresented populations. So the populations like patients and individuals with sexual minorities, disparities. That's what we're going to be looking at next month.
I think what is important for the next month is also this is a presentation of a study that was done in Nigeria. So it's going to be more like a panel of 3 people who have worked in Nigeria, and they're going to be able to share their work in Nigeria. Why is that important? It's important for people to understand what is going on in Nigeria, and that's one of the things we highlight here. So if you do have a project that you're doing in Nigeria, this will be a nice forum to be able to share that with people. So next month, we'll be sharing the work that Population Council is doing in Nigeria, and we're looking forward to joining them next month in terms of that. And if you missed any of the monthly webinars that we have, Professor Nyeka has put in the chat box for you to see. They are posted in 2 places. They are posted on our YouTube channel. They are also posted on our website. So, and the slides will be available at those places. We are not going to be sending individual slides to people, but you can go to our website. You can see those slides. You can see a recording, not just from this particular presentation, from every other presentation that's happened. You can also go to the YouTube, whichever one is your preferred choice. But you can see this presentation today, and you can see previous ones. And then you can always check in there for what is next. And we should be posting for our next month what should be there. Thank you, everyone, for attending.
Thank you, and bye-bye.